So good morning all. Are you able to hear me in the back? Okay, fabulous. And thank you so much for including us in your program. We at CMS are committed to fulfilling the mission to create a healthcare system that delivers better outcomes for our beneficiaries. We focus on improving quality and also delivering a healthier population and reducing healthcare costs through improvements. So, having the patients and families front and center is exactly the right approach as far as we're concerned. So thank you for including us. And just by way of framing, we are very engaged in different processes through which the rules of engagement are established, refined, and implemented. And all of this has tremendous opportunity, and we would invite input from patients, from families. And I will tell you firsthand, in many scenarios, one being the conversation of what quality looks like, that conversation, the outcomes of those conversations are very different when we have patients and families with us as included in the process. So we are really eager to make this the start of a conversation rather than the conclusion of one. As you know, CMS is a large purchaser of healthcare and responsible for the care and keeping in some way of 1 in 3 Americans, and that population is growing, it's expanding, it's becoming much more heterogeneous and complex, and it's becoming heterogeneous in a way that will be challenging for us, in that patients with multiple chronic conditions, with chronic conditions that patients and families are able to survive but then must deal with, is a growing proportion of. So how we actually deliver health care is also changing and needs to change in order for us to meet the needs of this heterogeneous and complex population. So we're moving from, I used to call this the current state, but now it's no longer the current state because all that has been in play. From the previous state of being a very producer and provider-centered system, which is volume-driven, really, delivering services regardless of outcome, services that are fragmented, providers that don't communicate or coordinate, a really non-system predicated on individual episodes of service or service delivery. And that's really not been sustainable. So we are moving in the direction, in parallel, both private sector and public, in the direction of a more person-centered system, outcomes-driven rather than service delivery-driven, a system that is better coordinated, where the expectation is for providers to communicate and coordinate with each other and center that care around patients and families, and are also including in that the payment systems that are necessary as far as driving those changes and that frame shift in focus. So being that healthcare transformation is underway, what would it look like at the front lines? It must include the following components. And these slides are available to you, so I will just briefly highlight that it must include measurement of quality. And that quality has to inform and be in the direction of delivering outcomes that are desirable. We also have an opportunity to align that measurement around those outcomes in a patient-centered way, and also take advantage of the information technology that is also being supported, and create incentives to both utilize that infrastructure and deliver outcomes that matter. So how do we actually focus on, and what should we focus on? So here are some questions to run on, and I know many of you are in the research community, as well as in the advocacy community, as well as in the clinical practice and policy community. So what are the outcomes that matter most to patients and families? This is a question that we have asked time and time again to different audiences, and by and large, the responses are very similar. So for patients and families, they desire to have their symptoms effectively managed so that those symptoms don't interfere with their daily function. Being able to function matters tremendously and engage in their environments and in their lives as people as opposed to patients who focus on their symptoms. Function matters tremendously, their goals of care matter tremendously, so why not develop a system that drives towards that? Then how do we best align ourselves within settings, across providers, across research, clinical practice, and policy, so that we drive towards what is common to that focus, that desire to achieve meaningful outcomes, and then how can we identify what the obstacles are that we must overcome. So that's an important way of me saying why we are here today. And so that we can actually point out what the paths are to enable meaningful engagement that will deliver the desired health outcomes on behalf of patients and families. Now, this is just a diagram of the different policy and program levers that CMS currently implements. We have two of our leaders at CMS, Lisa Parker and Jim Rollins, who represent the clinical standards group. They write the conditions of participation for all facilities that Medicare participates in. So that includes from hospitals to post-acute to chronic care, all of that work, the definition of the rules of engagement that the surveyors then operationally will look for compliance with, that work happens in Lisa's shop. We also have our coverage determinations. So just so that I don't neglect to mention it, in order for services and treatments to be delivered, there must be a benefit category, must fit into a benefit category, and there must be a decision, a determination of whether or not Medicare could cover or should cover a treatment or service. Now, those decisions are predicated on the evidence that exists to say that a X, Y, or Z service or treatment is reasonable and necessary to achieve better outcomes for Medicare beneficiaries. And that work happens in Dr. Rollins' shop. Now, that's an important distinction because the conversation that we often receive outreach from advocates to say, we want you to pay this amount for a service. That's actually way down in the conversation, and the conversation really is one that doesn't include CMS because all of that, how much is paid, is determined beyond, the market sets that. That is not what the clinical standards and quality shop actually focuses on, which is on the evidence that supports a decision to deliver better outcomes. And any of you who are working in the diagnostic category space, results from a diagnostic test, whatever it is, should be used meaningfully in the care in determining what the management is for a given patient. So that is also taken into consideration, but ultimately management should translate into better outcomes. So again, it is about the evidence, it's about the outcomes, and what outcomes matter to patients and families is what we need to know and what we desire understanding. Now, this is actually the domains of the National Quality Strategy. There are 6. I would call to attention just the focus on patient and caregiver experience of care. That element or that domain has been integrated in every single care setting that has a quality reporting program across our healthcare system. So it actually is an important signal that what patients and families experience matters tremendously. And in addition, we also have now a new reporting program, which is the cancer hospitals, which the first iteration of includes measures that translate and are similar to what is proposed and required in the acute hospital setting, but still patient engagement matters tremendously and patient experience of care. So we recognize that the CAHPS is, although implemented across all care settings, is a starting point. We desire the ability to measure outcomes, patient-reported outcomes, and how we do so is dependent on having a data source available. So that is important work that can be done to bring together a data source that can inform what patients' experience of care is, what their level of function is, what their self-reported health, all of that matters tremendously. But currently, there is no mechanism to measure that. So, now, I mentioned quality reporting. Quality, we had an earlier conversation about value. And what is value? How do we measure value? How do we deliver higher value care? Value, from our definition, is computing together quality and cost. Ultimately, we would like to achieve value that is defined as higher quality at lower cost, but also stable quality at lower cost would be completely acceptable, or stable cost at higher quality. But what we do not desire is moving in the direction of higher cost and lower quality. That actually would not serve patients or families well. So the principles of value-based purchasing are actually defined in the article that I referenced, but built on quality measurement. We have value-based purchasing programs in place, including the hospital and stage renal disease facilities and the evolving physician value modifier. This is a diagram of the measures for the inpatient quality reporting system that include experience of care weighted at 30%, that is similar to outcomes. And that has been increased over the subsequent years, sending a strong signal that what patients and families experience matters tremendously. So, over time, value-based purchasing will evolve to be more outcomes driven. Once we have quality reporting measures that can be reliably reported, and an inpatient quality reporting for hospitals must be reported publicly for a full year before it's even considered for implementation of value-based purchasing. But we know that this will take an iterative approach all along. Patient being at the center of that measurement construct is a commitment that we have made. So how do we know what measures exist? And we actually utilize the National Quality Forum as a consensus body entity to vet the measures for consideration for endorsement, and also NQF currently holds a contract for the measures application partnership. That is, it is now a requirement for there to be proposed measures on a measures under consideration list as part of the federal rulemaking process. And I mention that because that is a second opportunity to weigh in as to what measures make sense for implementation, as well as what measures stand the test characteristics that of importance, feasible, and all that's implicit in a endorsement of a quality measure. So you have endorsement and then you have implementation. Both are opportunities to engage and provide input into that consideration. And in the NQF, on the NQF website is a quality reporting system catalog called the QPS that you can actually search by condition, by diagnosis, by setting, and you can come up with a list of quality measures that include endorsement status, who the measure steward is. So it can be very informative as far as if you look at a measure, find something that makes sense but needs to be tweaked a little, you now can find who the measure steward is to engage with and have a conversation with, as well as a data source. So, and importantly, that can also be used to assess where the gaps are or the opportunities for research to support evidence that will inform a quality measure that could be developed. Now, there's much in common with other efforts, including the HHS effort to improve care for persons with multiple chronic conditions, and also the National Alzheimer's Project Act that focuses on both what matters to patients, but also what matters to families and caregivers. And what you can see here from the multiple chronic conditions work is that some of the themes of what is important to measure and what outcomes should we drive towards. Care that is safer, that does not result in harm as a consequence of that care. Care that delivers the ability to maintain function despite the ongoing presence of disease. Avoiding those preventable events that result in hospitalization and emergency department visits. These are pretty universal concepts that are applicable to all persons, all people, as well as patients, regardless of their disease category, but really matter most to patients who have and people who have multiple chronic conditions and specific chronic conditions that threaten life and function. So we actually do have interest in patient-reported outcomes and working with the Office of the National Coordinator on identifying where the gaps are in outcomes, as well as developing a system and sources for measurement. We have alignment on the inpatient and on the facility side to be able to measure function across care settings, but also the opportunity and a bridge to align with patient-reported assessment of health status and outcomes. Over time, we'll be standardizing that data, those data elements, so that all can understand and have a universal lexicon, as opposed to be using different definitions in different ways, so that you actually have a universal translator when it comes to measuring outcomes for all persons that Medicare is in charge of the care and keeping of. So, over time, we desire a system that is well aligned around what matters to patients and families, that we can measure different levels all the way from the patient level up, roll up towards facilities, but also that permits each healthcare provider to know what their role is in contributing to those outcomes. Right now, there is no method of assigning that level of attribution, or the methods are restricted to just hospital reporting or ESRD reporting. But patients float from hospital to ESRD to post-acute care to the physician's offices. All along, I think there's tremendous opportunity. So where can you get engaged? So this is external to CMS, but nonetheless, we value the input that the National Quality Forum and a consensus body entity provides, because that represents exactly what the name implies, which is development of consensus. There's the opportunity to be involved at the board level, as on the steering committee level, as well as providing public comment when measures are considered for endorsement, as well as when they're considered for implementation. And the dates of different project meetings are published on the NQF website. There's also an opportunity to provide comment on draft reports. Once those sessions have occurred, they always post for public comment any consensus project before it is finalized. So multiple opportunities to weigh in and contribute to the process. Now, we also, and this is just the process by which rules, the quality measures and concepts are considered, integrated, proposed. Lisa, I think, will be touching a bit on the rulemaking process for clinical standards, and I think that tends to be a process that you can actually set your clock by. We have a rulemaking calendar, and need to abide by that as well. But there is opportunity for public comment and input at multiple steps during the way. And really, the goal of this whole process is to arrive at the end with measures, with programs, with policies that are accurate and precise and speak to what matters most to patients and families. Recognizing we need to balance what the competing priorities might be. There might be something specific that the cancer community desires that may not be applicable to the cardiovascular community. And that's fair, but it is necessary for us to try to look for the sweet spot that is common to across different disease states. Because in fact, as the population ages and as we succeed in our treatment and management of individual conditions, what is left is a population that has not just cancer or heart disease, but likely both. So what matters to patients rather than a disease is what we try to focus on. So there is general education and outreach and opportunities to also share your ideas, particularly with the Innovation Center. As you know, there are multiple Healthcare Innovation Awards, round 1 that has been awarded and is well underway, round 2 that is currently in play, that includes a focus on vulnerable populations, frail populations, and patients with complex conditions, cancer care being one. How do we actually provide care that new care models and new payment models that then deliver higher value at the end? Again, that is higher quality, stable or lower costs, or stable quality at higher costs. How do we achieve that? And you actually have opportunity to inform that, what that looks like. And finally, as the system evolves, we are moving in the direction of developing a learning health system. So each time we experience that there is a failed clinical trial, not to discard that, learn from it. If there's a program that doesn't deliver what you expect, why didn't it? Let's learn from that. Each of these failures, there is no failure, it's only learning. So how do we shift from failure to learning mode and each time have a iterative opportunity to improve the programs that again deliver better outcomes for patients and families? And this is a learning system that is applicable to all persons from birth to death. And as a gerontologist, it really is quite well aligned with that principle. This is not a matter of, although the benefit categories for CMS for Medicare are defined specifically, for Medicaid they're defined specifically, but people grow through and age from birth to death. So therefore, what we learn about our health system and how to improve should be applicable to those people regardless of where they are in the administrative construct. So I return to the initial questions. So what are the outcomes that matter for patients, families, for health systems, and how do we best align so that we can deliver to those outcomes, irrespective of the artificial boundaries that we have across care settings, across providers, across research, policy, and clinical practice? And how do we develop tactical plans to overcome the obstacles that are in our way? So thank you for your attention, and I believe we'll be turning it over to Jim. Dr. Rollins.
First.
Oh, thank you. Thank you.
Thank you so much for joining me, and thank you. So good morning, everyone. It's great to see you. Thank you for joining us today. I'm Linda House, the Executive Vice President for External Affairs, and I look forward to the opportunity of meeting some of you who I haven't had a chance to meet. Thank you for being here. So just a couple of things. We're going to move into our panel discussion with the folks from CMS, and then we're going to open the floor up for questions. So know that we'll bring all 3 individuals here and open the floor up for your questions as a part of that. I do want to remind you of a couple of things. Number 1, you will be receiving a toolkit from this meeting. A couple of pieces to that toolkit. The slides will actually come to you within the next 2 days. So if you feel like you're missing anything, you're not. We're going to be sending those out to you within the next couple of days. Those will also be posted to the Cancer Policy Institute website, a particular section for this meeting. We are also video recording all of our speakers. So for those of you who want to just catch up and listen again to the messages that you're hearing today, or if you have colleagues that you feel like, oh gosh, I really wish that they would have been here to listen, that'll be available to you within the next month as well. So just know that those are a couple of pieces of information. The other thing I want to mention to you is for those of you who have these things, I am tweeting under the hashtag Uniting a Community. So I'm trying to tag as many of you as I can with my 140 characters, but that is a little bit challenging. I will say that CMS is at CMS.gov, so for those of you who want to tag them, and Lisa is going to follow the hashtag later to see what comments come in. So I encourage you, if you hear something compelling that you want to send it into the Twitter zone, please do that, and we'll try to capture that and retweet. And so without further ado, I will introduce Jim Rollins and Lisa Parker, who will be our next speakers. Jim is the director of the Division of Items and Devices for the Coverage and Analysis Group, and Lisa, when she joins us, is the director of the Division of Institutional Quality Standards for the Clinical Standards Group. And the insight that they'll provide us will be invaluable to our next steps together with CMS. So thank you both.